Morning, everybody. It is the last week of lecture. It's week 10. It's spring of 2020. This is going to be the lecture for Monday and the lecture for Tuesday. So that's going to take up that's going to be the end of the prostate portion of the class. And then we have one more long lecture on Thursday, and then we're done with the class. All right, so here we go. Prostate examination, we went through that in detail. Remember, you have to pop in next quarter. You'll have assigned time because you have to demonstrate proficiency in the actual prostate exam. But we'll talk a little bit about it here in lecture as well. So the size of the prostate doesn't always correlate with the severity of patient symptoms. So just because you have a huge nodular prostate, it doesn't mean it causes much symptoms. It usually does, but it doesn't have to. And the size of the prostate doesn't always relate or correlate to the degree of urinary obstruction. It usually does, but it doesn't always. Before you even do the prostate exam, and I don't think I talked about this in lab, there's 4 things if you really want to check out the prostate for completeness. Symptoms of prostatitis versus BPH. There's 4 things that you have to do in addition to just the prostate exam. So a general physical examination of the patient, a digital rectal exam. Remember, we talked about that. That's leading up to the prostate. You can do that in females as well. And then a neurological examination of the perineal region, which includes part of the prostate. I mean, this kind of goes back to the digital rectal exam. Remember, that was part of it. We check the ability of the patient to clamp down on your finger, checking the tone of the external anal sphincter. And then there's a perineal reflex called the anal wink reflex, which is mediated usually by the S3 root, where you can stroke the skin around the anus, and the anus will contract. You'll get a reflex contraction of the external anal sphincter, so that should be intact. And then a urinalysis checking for any red blood cells, white blood cells, protein, specific gravity. So a run-of-the-mill urinary analysis. And then you've done a really complete prostate exam. Remember, the prostate normally palpates as smooth. It has the hardness of an eraser, so it's a little soft, but it's firm, but not boggy or mushy. If hardness, a word for hardness, probably won't use hardness on the test. Induration means hardness. So add that to your vocabulary list if you don't know that. So if there is significant induration, then you have to think the prostate is cancerous, and then you have to order or refer out to a urologist if you want to. Somebody has to order PSA testing. You could do that, prostate-specific antigen. Best that the urologist or proctologist orders the transrectal ultrasound and a transrectal biopsy. Those have to be done anytime you find a rocky hard prostate. I do like my differential diagnosis slides. So here are the differential diagnoses to BPH. We're still finishing up BPH. Did I say that, where we are? No, I didn't say that. But we didn't quite finish BPH. But there are some differential diagnoses. So prostate cancer can also compress the urethra and cause dysuria. So that's got to be at the top of your list of differential diagnoses, especially if the patient has dysuria, has trouble starting urination, and all those symptoms we talk about. Could be urethral constriction or stenosis, especially in kids. Some kids are born with maybe the penile urethra is very stenotic, and you can't get urine out that way. Or maybe there's a tumor inside the penis and it's compressing on the urethra. maybe a contraction of the bladder neck or contracture. Maybe the bladder neck is spastic and compresses on that part of the urethra. Obstructive bladder stone can block the opening to the urethra. A urinary tract infection. The bugs can inflame the wall of the urethra, and the inflammation can cause swelling in the wall of the urethra and compress the lumen of the urethra. So that's another possibility. And side note, BPH increases the chance of urinary infection as well. Maybe the patient has a huge disc herniation, right? A central disc herniation compressing the S3 root, or maybe it's stenosis, or maybe it's aneurysm. Anything compressing that thecal sac can also cause symptoms of a neurogenic bladder, right? Usually you can't start urination. I got a YouTube video on that. I did quite a while ago, but it's in there somewhere. Diabetes mellitus. They have trouble with going to the bathroom. Sometimes the wires get damaged. S3 root gets damaged by all the sugar. And certain neurological diseases, stroke, and anything that causes severe central vertebral stenosis and squeezes the thecal sac down. Degenerative change, disc bulging and ligamentum flavum, and a degenerative spondylolisthesis can all cause central stenosis, sometimes severe. Usually degenerative spondy doesn't, in and of itself, it doesn't go past a grade 1. But it's usually associated with disc bulging and ligamentum flavum hypertrophy, and that can significantly compress the thecal sac. But when you think of neurogenic bladder, you always think of an acute problem like a big central disc herniation or an aneurysm that's formed in the blood vessels, the epidural plexus of blood vessels that surrounds the thecal sac. That's the things that pop into my mind. What about the treatment strategies for BPH? Well, there's 3 treatment strategies. You can do nothing and just see how the patient does. You can give the patient medication or medical therapy, or you can do surgery. So let's take a look at these. Watchful waiting. So if you remember, we talked about the IPSS test that you can take and how good that is to do. If you score low on that, between 0 and 7, then it's best just to watch and see what happens. Men with higher symptoms, 10, 11, 12, 15, 20, even 35, they can choose to be managed that way, but you have to be careful because they are going to damage the bladder. I was watching a surgical procedure on BPH with severe dysuria. I came in through the bladder and took the prostate out, and my God, that thing was so big. But the bladder was also hypertrophic, obviously hypertrophic, and the surgeon commented that they always see hypertrophy in the bladder by the time it gets this far. So you don't want to ruin your bladder, so be careful with that. You don't want to, I probably, if you were just had a little problem, maybe you can do watchful waiting. But if you're having significant problem going to the bathroom, you probably should get one of these, at least try the medications. Medications are recommended for IPSS scores that have gotten over 7. There are 4 main types of medical therapy. Well, one's kind of a fringe medical therapy for BPH. And really there's 2. There's alpha blockers and there's 5-alpha reductase inhibitors. Or you can use a combination of these. This phytotherapy, I'm not going to take any more talk about that. In Europe, it's more popular. But that's more of a naturopathic way. They use natural herbs and plants and things like that. It's not supported by good quality research, so I'm not a fan of that. I don't think in this country we're that much of a fan of it. That's 5-alpha, it's the alpha blockers or the 5-alpha reductase inhibitors that are kind of the key. And how do you know which therapy to try? Well, you don't unless you get a histological sample, which you have to do because you've had a prostate exam and they found the prostate to be large and you need it to get a little piece of that prostate tissue to see what the cell type is. So if the enlarged prostate tissue, which we'll just call nodules, If they're made of smooth muscle, which they could be, sometimes smooth muscle proliferates, then it's best to use an alpha blocker therapy. Alpha blockers, they block the effects of the sympathetic nervous system. And sympathetic nervous system is thought to influence I think we talked about this, but you can get smooth muscle hypertrophy from increased sympathetic tone is the theory there. So you can block that with an alpha blocker. Might have other beneficial effects on the body for people with general increased sympathetic tone, like hypertension and certain types of hypertension. If the patient's histological sampling comes back with an epithelial type tissue or a glandular type tissue, the nodules were made of epithelium, then they respond well to the 5-alpha reductase inhibitor, which blocks the formation of DHT. And we talked about how DHT can cause growth factors to be released, and those growth factors cause a proliferation of that type of epithelial tissue. So it works good. If the histological sample comes back that you really mainly have collagen or a scar type tissue, then you're kind of SOL. Medication doesn't work, and you're looking at having that thing removed. So there's a couple of ways to treat surgically enlarged prostates. One is called transurethral resection, where they basically rotoroot. They go up the urethra. Doesn't look like the most fun procedure in the world, but I'm sure this is general anesthesia, so you won't feel anything. I basically stick a catheter up the penis through the urethra, and they come to the blockage. And then they take this little wire. It looks like this. I just watched a video on this bipolar method. It's really cool. It's got like a wand here, and then it's got this loop. And the surgeon can control whether or not this is on. And in an instant, by pushing a button, this thing will glow, almost glow red. It's super hot, and it slices through tissue like nothing, like slicing through butter. And the litter, he keeps talking about in the video, mowing the lawn. He teaches it. He's a professor of this type of surgery, and he teaches the students to cut the lawn who are going to be urologists. And it's like cutting lawn, and you shave from the inside out. You shave and shave and shave and shave until you come down to the verumontanum, and you want to make sure you don't go out of the prostatic capsule. And you won't shave all the prostate away, but you open up that prostatic urethra like before. You destroy the urethra and the epithelium, though, but it scars back over. And although you won't have epithelial tissue, as the lining of the lumen, it doesn't seem to matter. The scar tissue seems to work just fine. So less complications with this surgery. I would definitely go for this surgery before I went through for any type of surgery through the bladder to remove. Here's that movie. There's a link to it on YouTube. But you can see the wire right here. This is an endoscopic view. This is the urethra of the penis. He's almost done with the procedure. It's just a little bit of tissue flapping around, but he's literally shaved this thing down. I mean, this hole was about this big when he first went in, and he shaved all this tissue away to recreate this. Right now the wire's off, but it gets really hot. Like a orange, almost a white orange, super hot color. But very cool video if you want to watch that. Right, here's another look at this transurethral resection of the prostate, where the catheter goes in. Called, what do they call it? A resectoscope. And you park it here. You go all the way up into the bladder. So your urethral sphincter is definitely going to be in trouble on this one. And then you start shaving away. And so that's the procedure. It's called a TURP. He called it many times a TURP. There are TURP, transurethral resection of the prostate, TURP. So there are some problems. Interestingly, he didn't talk at all about the biggest one, retrograde ejaculation. So if you're trying to have babies, when you ejaculate, you need the external urethral sphincter to shut. So sperm, because sperm is going to be, it's been stored, and you got prostatic and seminal vesicle juice. You don't want that to go backwards. And so this procedure destroys this internal urethral sphincter. And when you ejaculate and the prostate contracts, some of it backwashes into the bladder, and you become sterile. That's called retrograde ejaculation. And there's other ways for that to occur. You can even an ALIF, the Tiger Woods surgery, there's a high chance of that happening for injury to a sympathetic plexus in the area. So there's other ways to get retrograde ejaculation, but that's what it means. When you ejaculate, instead of going out your penis, it goes back up into your bladder. So in addition to retrograde ejaculation, I think we said everything. Other complications are infertility, dry orgasm. These should have been out here, right, in their own category. I think I'm just to tidy that up a bit. I just did these slides this morning, redid them. Dry orgasm. Part of the experience of an orgasm is that the fluid coming out of the penis. And if you have retrograde ejaculation, when you ejaculate, nothing comes out because it goes up into your bladder. So kind of, some say it decreases the pleasure of an orgasm. The nerves can be damaged, and in 7% of people, they become impotent. And even worse, if they damage the internal, which they usually do, but if they damage the external, the one that's under voluntary control, now you can't control your urine. And so you become incontinent. Luckily, that's only less than 1% of the time. Other surgical treatments. So we have a prostatectomy, or a subtotal prostatectomy. These are done through the bladder. Well, there's a couple ways you can do them actually, but there's a lot on YouTube about and the research about the Da Vinci robot. I watched a video on that, and it's like, oh my God, that's like amazing how the little hands, the little robot hands can be worked, and they're so precise, and he can sew even a blood vessel, a tiny blood vessel leaking can be sewed shut. So it's amazing. So you can basically come in through the bladder and just remove the prostate by working. The workspace would be the bladder, and you could go down through the neck of the bladder and remove the prostate that way. You can take some of the prostate out. You can take all of the prostate out. Transurethral microwave therapy. You can burn the prostate away. You can vaporize it away. You can laser it away. There's lots of different ways to open that pipe back up. All right, so that's all we'll say about BPH. Now let's get into a big topic here. This is prostate cancer. It's the most common form of cancer in men, period. Now, this is worldwide. It's actually in the U.S., it's the second most type of cancer behind lung cancer, but they're pretty close. 80% of the cases are diagnosed in men over 65, so a big chunk of men get this cancer later in life. And not just because you have prostate cancer doesn't mean you're going to die. Many of these cases, the patient dies of natural causes before the cancer really even gets going. So it's not necessarily lethal, and it has many different faces. Some of the cancers can kill you very, very quickly, very aggressive, especially if it metastasizes. Some of the cancers grow like a turtle, and almost like we're going to talk about lentigo maligna, and lentigo malignant melanoma is a skin cancer. It's a dangerous cancer, skin cancer in the face. It's melanoma, but its pre-cancer form, lentigo maligna, can take decades to turn into real cancer. So it's kind of like that. But that's the challenge with prostate cancer is. That's called heterogeneity. It's got so many different pathways. It's hard to diagnose, and it's hard to predict a prognosis, and therefore, how do you treat it? You don't really know how to treat it. And we'll look at a couple of the treatments at the end of this. Still, the best way to start to catch it is to annually have a PSA test. And that's the trouble with PSA, as we said before, its specificity isn't the greatest, because not only is it elevated in prostate cancer, it's elevated in BHP, benign prostatic hyperplasia, and prostatitis can be elevated. And then sometimes some people have prostate cancer and they have normal level of PSA. So it's not a perfect test, but it's a good start. And I took all this out. I used to explain the Gleason grading, and we're just getting too deep into the weeds. So I took it out, but there is a way to grade histological sampling called the Gleason grading criteria. And yeah, that's the gold standard way to make the prognosis. And I do apologize again. It's Friday. I'm making this video, and it's garbage day. So we got one more round of garbage trucks we have to endure. Sorry about that. Second most common type of cancer found in American men, as I said, lung cancer is number one. It is the second leading cause of death, period. Let me repeat that. The second leading cause of death in American men is prostate cancer that's metastasized. Wow. Heart disease is the number one. It even beats out lung cancer death. The time of the diagnosis, about 50% of the cancers have already metastasized, and that's the problem with this cancer, right? So if you get the diagnosis, half of the time it's too late. The cancer has flown. So that's the problem with it. The other half of the time it hasn't, and it's probably the slow turtle-moving type of cancer. More than 2,000 cases are diagnosed each year. Kills more than 30,000 men per year. Good news is the mortality has been on the decline since the 90s. And look at this number. It's down. Mortality has dropped by 40% since the mid-1990s. Because of better surgical techniques and better understanding of how to make the diagnosis. This cancer, unlike other cancers, the older you get, the greater the chances you have for getting the cancer. So age is a definite risk factor. Now this is arguable. The lifetime risk of developing prostate cancer in our board books is 15%. I've seen as high as 70%. So this number could be much higher than that. But according to this source, about 3% will actually die from getting it. Risk factors: increasing age, being African American, positive family history of cancer, dad or grandpa have had it. The risk increases inversely with the age of the family member. So if the family member gets it when they're really young, your risk is much greater. If diagnosed at the age of 50, for example, there's a 7-fold risk that you'll get this cancer. Diets high in animal fat and red meat increase the chance. Diets high in fish decrease the risk. High intake of vitamin D and calcium. Those are also risk factors. High intake of vitamin E decreases the risk. Having a previous vasectomy. I remember back in the day when I was in college, this was very controversial. Vasectomies cause prostate cancer. That is probably not true. There's some very large studies, like the Cox study in 2002 said that's not true. There's online calculators. You can get an idea of what the risk is at that link down there. What about the location? 65% of the time it's in the peripheral zone. Talked about that. That's the part that we palpate. 15% is the transitional zone. These are the ones, remember that's the hot dog bun. There's the transitional zone in purple there. That can squish the urethra and cause a lot of dysuria, trouble going to the bathroom. 7% are in the central zone. So remember, we didn't talk much about this, but there's the capsule is very intricate and involved. But the bottom line, if it penetrates, gets out of the capsule, it's a bad omen. See all the blood vessels here, right here, and it grows in this part, right? Maybe it's in the left lobe, maybe it's in the right lobe. The surgeon kept talking about a middle lobe of the prostate, and I think he just meant the middle between the left and right lobe. I've never heard that before. And yeah, so if it's in one of these lobes, it can get into these blood vessels. Same in the front. It's easy to get out the front, but it usually doesn't start out here. But you don't want it to get through this red capsule. That's definitely a poor prognosis. If it gets out of the capsule and into the seminal vesicles, a terrible 5-year prognosis. So it's better that you catch it contained. There's 2 types of pre-cancer of the prostate. There's PIN, prostatic interepithelial neoplasia, and there's the atypical small acinar proliferation. We're not going to get into those, so I'll just mention those types. How about some fun facts? In 95% of cases, the cancer is an adenocarcinoma. Cancer will sometimes invade the bladder trigone. That's common. We talked about that with the esophagus as well, so it's almost always adenocarcinoma. It can invade the trigone of the bladder and cause obstruction that way. So we'll look at the places it likes to invade too, but it could do that. And anytime it compresses the urethra, that's obstruction. You have dysuria. Remember our bladder here, there was this really almost looked like stomach rugae. The detrusor muscle is the wall. And then we had this really smooth region, which is triangular and shaped. That was called the trigone of the bladder. And then we had the orifices for the urethra, or for the ureters, right there, or the os of the ureters are right there. That's what the ureters, remember, they come down. They come down from the kidney, and they go through the back and connect there. Remember those guys? Yeah, so you can get cancer anywhere in there. All right. Then we have this Denonvillier's fascia. Denonvillier's fascia is it prevents, it's really an interesting fascia. Did we look at it? Where was it? Yeah, it's right here. Denonvillier's fascia. It's pretty strong, but it's interesting. It doesn't let cancer get out. Cancer has trouble going that way. But if you get cancer of the rectum, that cancer can get in much easier. So it's kind of a one-way membrane, which is a little bit strange. Okay, one-way barrier, as I just said. Oh, there, I could have went one slide that way. And anyway, the lymph nodes. So it's a myth that you can catch prostate cancer by doing a lymph node exam in the inguinal region, because the superficial inguinal lymph nodes that you can palpate along the inguinal ligament, they're almost always spared. The cancer doesn't bother them. It's not. Sometimes the cancer can get there, so it's not that I'm saying don't ever do that exam. But most of the time, the big primary nodes that drain the prostate are the obturator, which is usually the first to be affected, and then the external and internal iliac. And then it moves from those iliacs to the common iliac, just like the vessels, named after the vessels. And there's a pre-sacral and pre-aortic. So it tends to spare those superficial inguinal nodes. I usually ask that's the question. People miss that one. They think, prostate will drain into the superficial inguinal nodes here at the level of the inguinal ligament, really just a little bit below the inguinal ligament. But yeah, the deep nodes are deep. The deep femoral nodes usually aren't affected either, and those are also involved. So the obturator nodes are too deep to palpate. But there's the obturator node, and there's the internal iliac nodes are here. They go on to the common iliac nodes. There's the external iliac nodes. So these are the ones that are affected and will be swollen up, but you can't see the darn things. It's the trouble, or you can't feel them. All right, if it gets out of the capsule, where do the little metastatic cells fly? Where do they fly and land? Well, when it spreads, the axial skeleton is the favorite target, and we can be more specific about that axial skeleton. And right, that's our domain. That's the spine. So specifically, in order, the lumbar spine is the number 1 favorite target. The number 2 favorite target is the proximal femur. Number 3 is the pelvis, the iliac crests, for example. Here comes our friend, the garbage truck again. And mind you, this is after 2 waves of garbage trucks have come by this morning already. So I waited until those came by. There's a garbage truck for the trash, for the recycling, and another one for the lawn waste. So 3 different garbage trucks come by. See, maybe I can put that on the final to see if anybody actually listened. Oh, wouldn't that be a tricky one? Because a lot of people aren't even listening to these lectures. So see if I can remember that in my brain, which I probably can't, having 5 lecture classes. Anyway, so yeah, lumbar spine is the number 1 target. Number 2 target, proximal femur. Number 3, any part of the pelvis. Number 4 is the thoracic spine, and then sternum and humerus aren't that really much of targets, although occasional. So what type of the cells that fly out of the prostate when they land in the lumbar spine, what do? They typically stimulate osteoblastic activity, and therefore they're typically an osteoblastic lesion, so the bone will look really white. And some of the clinical sequelae of this osteoblastic metastatic disease are pathological fractures of the spine, compression fractures, or low force fractures. You sneezed or you vomited something, or you lifted something moderately heavy and you fractured your spine and your vertebral body. So those are called pathological fractures. They're low force fractures. Vertebral involvement can also invade the vertebral canal. So osteoblastic activity is blastic. You grow new bone, and it can cause severe central stenosis, where the vertebral canal gets squished down and the thecosac gets squished. So you could present with the sequelae of spinal stenosis. These patients will come right into your office all the time. People with low back pain. They'll have radicular pain. Maybe they'll have real radiculopathy with that radicular pain. It'll be bilaterally usual. Should have probably added bilateral. Let me make a note of that. Unilateral, you don't have to worry as much. And then they'll have NIC, neurogenic intermittent claudication. Remember we talked about somewhere the difference between NIC and VIC, vascular intermittent claudication versus neurogenic intermittent claudication. Vascular was from what? It was from PAD, peripheral arterial disease, which really is nothing more than atherosclerosis of the abdominal aorta and common iliac arteries. They get severely stenosed by gunk, by plaque buildup. Causes a beaver dam, and when you walk, your muscles don't get enough blood and they hurt. And that's VIC. All right, let's do a case. 45-year-old male presents to your clinic, chronic back pain. In the past history, you see he had a prostatectomy 5 years ago for BPH, and that was successful. He's able to urinate just fine. Pathology report was negative for cancer. So you took an x-ray, just run-of-the-mill patient with back pain. What do you think? By the way, see the staples? To clamp off the bleeders, they leave the staples in, so prostate is gone. Yeah, some of you see it. That's too white, right? That's not good. That's osteoblastic activity. It doesn't look like it's expanded the cortex yet. I'm not 100% sure that there looks a little funky in here. Maybe going on. It looks kind of the same bilaterally, but that's a dead giveaway because it's not always osteoblastic. It can be osteolytic activity as well. Usually it blows out the pedicle when it's osteolytic. And so that pedicle is a little bit darker compared to that. So, but this is definitely osteoblastic activity. Anybody see anything else weird? I don't think this has anything to do with the cancer. What's that? Remember that ligament? From iliac crest to the lumbar, iliolumbar ligament calcification. May or may not. It probably doesn't have anything to do with the cancer, but okay, here, let's do another one. 55-year-old presents with low back pain and nick over the last 6 months. He has dysuria, so he's having trouble going to the bathroom, has hesitancy, decreased caliber of his urine when it does comes out. He's got dribbling. All right, you're suspecting prostate. Take some x-rays because he has back pain. That's why he's here for you. And, you know, a lot of you don't believe in taking x-rays. You get someone with complaints like this with these dysuriac symptoms, you don't take x-rays. In my opinion, you are not up to snuff. You're not doing your due diligence on somebody. If you don't have an x-ray machine, send them out for x-rays. How do you know it's not prostate cancer? You just can't go treating somebody and they have these associated symptoms that could be prostate cancer. You monkey around with them for 6 weeks, 3 months, whatever, you waste valuable time where they could be getting after this cancer. So you see cancer symptoms like this, you got to get an x-ray to see what you're doing. Anyway, what do you see here? Is he ready for treatment? Oh, you can't miss this. You can't miss this. Got it? So you guys are looking for osteoblastic activity. Remember, I just said it's not always osteoblastic activity. Some of you going, oh, it's osteoblastic here, a little bit more here than here. That's not enough to arouse suspicion. Okay, some of you saw it. Look at the pedicles. Oh, you got the winking. Remember, you always look for the little man. There's the 2 eyes are the pedicles and the nose. Always look for the little man. See, hi, little man. There's another one. Little man. Some of you seeing it now, aren't you? How about up here? There's the, there's the nose. Where's his eye? I mean, you can kind of hallucinate it in. Yeah. So he's got metastatic cells from the prostate have landed in his pedicle, and they've eaten away the bone. Right? So that's not cool. That's got a name, actually. It's called the winking owl sign. The winking owl sign. Breast cancer can do this. Lung cancer can do this as well. Prostate cancer is usually osteoblastic, but not always. If I saw this in a female, I would think breast cancer. It's the first thing that would come to my mind. Second thing would be lung cancer. Third thing would be, if it was in a male, especially with dysuria, I would think prostate cancer. But nevertheless, this is metastatic disease. He's got to be referred out immediately to who? You tell me who you refer him to. His primary doctor? Why would you do that? It's just then he's got to get an appointment with the primary doc. I mean, you're wasting a couple weeks. You refer him right to an oncologist who treats cancer. Let the oncologist work him up. All right. The metastatic disease doesn't always hit the bone. It can also hit soft tissue. And where's the favorite soft tissue for this prostate cancer to spread to? The lungs are number 1, followed by the liver, and then the adrenal gland. Some people, we talked a lot about this quarter about Addison's disease. Sometimes it's caused by metastatic disease from the prostate. It's the third most common. Not the third most common cause of Addison's, but the adrenal gland is the third favorite soft tissue target. So you can bet some questions are coming on these targets, especially when it involves the spine, so make sure you know that. Let's do another one. Some of you are going, oh my God. But remember, if there's one problem, there's no law that says there can't be two. So we got a 62-year-old male complains of low back pain and chronic cough. For the last 8 months, to have a chronic cough for 8 months, that raises an eyebrow. So 4 weeks ago, he developed some upper quadrant pain, and now he's got gut pain and bloating as well. And now the last 2 weeks, he reports constipation, obstipation. What's that mean, obstipation? Good. He hasn't had a bowel movement in 2 weeks. Or he's severely constipated and only had one bowel movement per week, and he had to use his fingers to pick it out of there. That's obstipation. So past history reveals he was diagnosed with BPH 10 years ago. The question, was it really BPH? So what do you see? Oh, look at the lungs. They're filled with these little kind of cotton wool blobs all over the place. Really bad omen. Those are all cancer cells from the prostate. So he's developing wild growth of the parenchyma of the lungs right here. But what about his obstipation? Good. Some of you saw it. Look at all that gas. Right? That's the large colon. So what happened? So he had metastatic carcinoma. So he's got lung cancer now. And he's got a intestinal block in the upper quadrant. Right? Specifically, the sigmoid colon was affected with cancer, and the cancer grew and grew and shut down the lumen. And so they have a large bowel. That's wrong. They have a large bowel obstruction, or you can just say bowel obstruction 153. Large bowel obstruction. We didn't talk about that, but it's just like small bowel obstruction. What about genetics? Yeah, there are some genetic tests you can do to see what the future holds. So mutations on many different chromosomes, 8, 10, 11, 13, 16, 17, 18, have all been discovered that increase the risk of PC, prostate carcinoma. These mutations can be used to predict the development of PC and its aggressiveness. Let's talk about a couple of mutations, and the mutations produce a growth factor, regulator. One big one is called ERG, for erythroblast transformation specific related gene. And this is one of the key transcription factors, grossly is oversecreted in not all patients with prostate cancer, but many patients. So specificity isn't super high in this one. It's a member of the ETS family. We don't really care about that. This gene is considered to be an oncogene because it's normally not found in high levels. And there's other places it's found, which we won't get into. But it is a transcriptional regulator of transcription. And it specifically regulates or controls the mitosis of cell proliferation, spread, and apoptosis. So if this guy's screwed up, cells proliferate like crazy and they don't die, and they can spread. They lose their basal lamina. They can spread like crazy. And the specific problem with this gene is it actually can get stuck into a chromosome where it's not even supposed to be. So we won't worry about the numbers, but it's chromosome 7 supposed to be. It gets stuck in chromosome 8. It's not supposed to be there. And that's called a translocation mutation. So it results in a gene that produces a product which fails to regulate mitosis, and cells proliferate like crazy and they don't die. All right, got to talk about the BRCA mutations, BRCA1 and 2 mutations. I think cancer. I should call them the cancer mutations. So a man with a family history of breast cancer, so the mom or grandma has breast cancer and ovarian cancer, without knowing any more, that's a risk for you to get prostate cancer. If you happen to know whether or not your mom or grandma had the BRCA mutation, either BRCA1 or BRCA2, then your chances of prostate cancer go way up. your chance of breast cancer in a male go up. If you're a female, your chances of breast cancer go way up. So a female with a BRCA1 or a BRCA mutation has a 70% lifetime risk for breast cancer. What? Yep, let me read that again. A female with a BRCA1 or BRCA2 mutation has a 70% lifetime risk for developing breast cancer. Should have added cancer there. 158. Okay. If it's present in either sex, it also increases the risk for either sex of mom or dad. It increases the risk of mom or dad, but the offspring's risk of pancreatic cancer as well. All right, what about the clinical findings? Well, this is going to be simple because clinical findings, the symptoms are basically the same as BPH. In fact, the majority, this is the problem with prostate cancer, if it grows where it normally grows in the peripheral zone, it's probably not going to compress your urethra. So how are you going to know if you even have it? Well, unless you get your prostate examined, and sensitivity and specificity isn't the greatest for that. The doc may miss it. So that's the problem. By the time they catch it, it's already metastatic. Let's see. Yeah, so symptoms are, if you do have symptoms and it turns out prostate cancer, that's a bad sign. It's probably already metastatic. The major complaint, though, maybe it's in the TT zone, the transitional zone. So then you get dysuria, but then again, the problem is, it's just BPH. That's normal for some guy my age, so you don't get tested. You don't get biopsied. You got to get biopsied for this stuff. All right, so it can be really tough to tell apart from BPH, though. How about other types of symptoms? Well, these are all just BPH symptoms, right? Hesitancy, decreased force and caliber of the urinary stream, a sensation of incomplete bladder emptying. You go pee, and then half hour later, I got to pee again. What's the deal? I didn't empty my bladder, I guess. Or double voiding. And then not only do you get the sense that you have to go pee, you actually go pee again. Then you just killed two birds with one stone here. You invoked both of those symptoms. Remember, there's a test for this. Straining during urination. You're going to wreck your bladder if you have to do that. Post-void dribbling. So you go pee. All guys dribble a little bit, but they dribble for half an hour afterwards. That's not normal. Painful ejaculation could be involved. Urgency, frequent urination, nocturia are all symptoms. Examination findings continued. So digital rectal exam may find signs of prostate nodularity. We talked all about that, a hard prostate or nodular prostate. Remember, it's supposed to have the consistency of an eraser. We already talked about that. And yeah, if that DRE is positive, though, remember there's 3 tests that have to be classically performed. The PSA has to be ordered by somebody. The transrectal ultrasound and the transrectal biopsy all have to be done. Doesn't always happen, but here's a 34-year-old male with stage 4 prostate cancer, and it got into the deep inguinal lymph nodes so bad that it caused a beaver dam of that important system. And so he went to the doc when his foot started swelling up. Right? So if the prostate cancer leaks out of the capsule, it can invade the inguinal system. And such a regional lymphadenopathy can definitely cause lymphedema, and it did in that case. Here's another one. I like this because I don't think a lot of you know this word, this azotemia. So, and this doesn't always happen, but these are kind of rare complications. That's a rare complication, but they can happen. So, azotemia means that you have your BUN, your BUN, blood urea nitrogen levels are really high. So you have too much nitrogen and creatine levels in your bloodstream, and that can only mean that your kidney's failing. That's called azotemia, when you have kidney failure and you have these nitrogen and creatinine levels. So how in the world can the prostate cause that, you may ask? Well, if the cancer is so bad that it's compressed the prostatic urethra, it's a beaver dam. And the pressure can go up into the bladder, and it can even go up into the kidneys. And it can even occasionally cause kidney failure because of this. Okay. We covered that one. Anemia is another. If the prostate cancer has gotten into the bone, it can cause anemia because it messes up the marrow, and hemopoiesis is screwed up, so you don't make red blood cells as good anymore, and you get anemia. And because of the bone destruction, you get alkaline phosphatase level increase as well. So we talked about PSA levels. Specificity is not the greatest, but I'm not a big one with numbers, but I do want you to know these numbers. So PSA, if it comes back 4 or less, it's considered normal. So levels between 4 and 10, actually that should be, let me change that on 166. It should be just less than 4. No, it's actually, that's correct. Less than or equal to 4 is no big deal. If it gets to 5 and above, right, 5 to 10, it's easier to remember too. Then you have about a 25% chance of developing or of having prostate cancer. If the levels are over 10, you have over a 50% chance of having prostate cancer with a PSA level that high, over 10 nanograms per milliliter. But we said the problem is the specificity is not the greatest, because people with BPH and prostatitis can also have this problem. Thompson published a study on this in 2004 and looked at direct relationship with PSA. They noted that occasionally prostate cancer can start with normal levels of PSA. So they concluded that you can still get prostate cancer without PSA, but that's not the norm. How about PSA versus 5-alpha reductase inhibitors? So here's another problem. BPH is so common, a lot of guys are on 5-alpha reductase inhibitors. 5-alpha reductase inhibitors can artificially lower PSA levels. So what happens if you happen to get prostate cancer while you're taking 5-alpha reductase inhibitors? You might not catch it, because even if it's elevated, the medication will lower it, so you can't catch it. So that's kind of would be bad luck, but it could happen. What about the treatment of PC? The optimum treatment for all stages is great. There's great debate on what that treatment may be, and it's very controversial. So you have to take in how old the patient is. If they're 95 years old, they're probably not going to live more than another 5 or 10 years at the most. And the prostate, if it's a slow-growing cancer, it might not be worth treating it. Just watchful waiting. And then you got to figure the treatment morbidity. I mean, radiation therapy and a surgery in somebody that old is pretty risky. And then, of course, the type of cancer and the stage of cancer that it's at. PC treatment options. There are androgen deprivation therapy, because testosterone will fuel cancer growth, so you can cut that off. Radiation therapy, that is isolated, shot with a beam radiation right at the prostate. There's freezing it, cryotherapy, hypothermia. You can fry the cancerous prostate with ultrasound or microwave. You can laser the prostate. You can use hot water balloon therapy, stick a balloon up inside your urethra and blow it up and inject hot water and try to cook it that way. And then there's probably the big one is the radical prostatectomy. Okay, so we're going to not worry about those other ones, but let's talk about the radical prostatectomy. There's a lot of AKAs, just prostatectomy, radical retropubic prostatectomy, radical suprapubic, and these are just describing different approaches to removing it. And yeah, nerve-sparing prostatectomy, etc. But this is a surgical procedure that removes the entire diseased, riddled prostate gland, and typically used to treat prostate cancer that is PSA levels are high and they're worried about this type of cancer. You can use it to fix BPH that's severe as well. Sometimes you just got to remove the entire prostate this way. And radical means they're going to take the entire prostate. Remember, I don't know if I taught you guys, but we had a cadaver section with its prostate completely removed who had undergone one of these procedures. You can also remove the prostate by going through the bladder as well. The Da Vinci robot does this quite nicely. I don't think that's made it into the board book still yet. So radical prostatectomy is only recommended for contained prostate cancer which has not metastasized. If it's gotten out of the capsule, then it's radiation, chemotherapy, and things like that. So there's two main approaches. There's one is retropubic, where you go over the pubic symphysis and go down, and one is you go right through the perineal region. Like I said, there's a Da Vinci procedure now, which is probably less invasive and seems to have good numbers. It hasn't made it into the board books yet. But the major risk for any of these procedures is you injure the internal external urinary sphincters, and there you go. You have no control over your bladder, and you have incontinence. You can damage the pudendal nerves, and there goes your erection. You can't have an erection anymore. So there's impotence is a problem. Urinary continence is a problem. Sterility, if they blow up the internal urethral sphincter, you become sterile because of retrograde ejaculation. Lymphedema, we saw a guy with lymphedema, scarring, and that can happen from radiation as well. If that lymph system is damaged during the surgery, it can scar up, and now you got a beaver dam and lymph backs up into your leg. What about some bad omens? Again, if the prostate cancer has went through the capsule, you're in trouble. That's, and we said 50% are caught. It's already gotten loose. The nodes have to be biopsied, the inguinal nodes, or not the obturator nodes, and the internal external iliac nodes, the common iliac node, all that gang has to be biopsied. The pathologist discovers cancer on the results of those biopsies, then there's an 85% chance that it's spread. Doesn't mean always. Sometimes the node is doing its job and captures the cancer. But if it's spread out, you're in trouble. And again, it loves the lumbar spine, and it loves the soft tissue of the lungs. Good omen. So if the cancer is confined to the prostate gland and the lymph node biopsies are normal, and it hasn't gotten into the seminal vesicles, 10-year survival rate's about 77%, almost 80%. So 20% are still lost, but that's pretty good. If it has gotten through the prostatic capsule, whether or not it's went beyond the nodes doesn't matter. If it just breaks out of the capsule, about 60% of people will be dead within 10 years. To cut or not to cut? So does a radical prostatectomy actually prolong life in patients with localized cancer? I mean, if you're going to do this radical procedure, cut out the prostate gland, is it worth it? And so this famous 2017 New England Journal of Medicine, I mean, very prestigious journal, they say maybe not. So let's take a look at that paper. That's the Wilt paper. Part of something called the Pivot trial. But they took 731 men with localized prostate cancer to get in the study You can't have a high PSA. The average PSA was about 8. And then they took these patients and they just randomly threw them into 2 groups. One group had, and no crossover, one group had the radical prostatectomy. The prostate was cut out with the cancer. The other didn't do anything and just waited to see. And boy, I would have been nervous about this. And then they followed them for 12 years to see what happened. And a very surprising result. 64% of the whole cohort was dead by 12-year follow-up. But when you break the deaths down, they're pretty darn similar. 61% in the radical prostatectomy group died. 66% died in the watchful waiting group and didn't have all the morbidity associated with that prostatectomy. But you have to be careful. I was a little disappointed with the journal and not saying this, because the p-value for significance, right? P-value 0.05 is significant. So if this value would have been 1/100th lower, the whole study would have changed. And they said, yeah, radical prostatectomy is worth it because it did significantly save 5.5% more people. But because it was 0.06, they said, no, it's not worth it. And they really shouldn't show that. I mean, I work for a prestigious research institute, and I was taught very the hard way about that. You have to say the study suggests that the prostatectomy was superior to watchful waiting. The word suggests means it's super close to clinical significance, 0.06, maybe 0.07. So I would still do the radical prostatectomy if it was me, heaven forbid. Okay, and I go on that little ramp there. And then they followed them, the ones who were alive for 20 years, and about the same number of deaths was seen. So the authors concluded radical prostatectomy was not associated with significant lower cancer mortality rates at 20-year follow-up. They should have said it was suggested, radical prostatectomy suggests a better outcome, but it was not statistically significant. So it's a closer call than they think. Anyway, what about another type of treatment? Radiation therapy. You can use external beam radiation, XRT, and they blast the prostate without hitting the rest of you. And there's a problem with this, though. There's recent research, it's not in the board books yet. Recent research shows that about 30% of patients don't get proper exposure. The radiation doesn't hit the target correctly, and therefore the cancer is not being exposed to radiation. So that's a problem. Radiation plus the androgen deprivation therapy, which we'll talk about in a second, is usually used in combination with androgen deprivation therapy. There is statistical better outcome with these two together. So androgen depriving therapy blocks testosterone, and we know testosterone fuels the growth of cancer cells. And there's some drug strategies you can use, luteinizing hormone releasing hormone antagonists. So they block the receptors for luteinizing hormone, which is needed to make testosterone. There's androgen inhibitors. There's anti-androgenergic or androgenics. And yeah. The side effects to the radiation, or the side effects for the radiation are significant. So you could damage the prostatic urethra just by the radiation. It could cause scar tissue, and you can get a beaver dam, and it can wreck your bladder and kidneys. It could cause pain when urinating. It can cause urgency. I mean, it's radiation. It destroys tissue. It can cause rectal and bladder cancer, right? It's radiation causes cancer. So it doubles the risk at about 10 years. If you've undergone rectal or bladder cancer radiation therapy, you have a double the chance of having cancer of those structures, again, because of the treatment. All right, prostatitis, and because I had to go down to Costco, I have absolutely no idea how long I've been going, but Let's get through this. I don't have many slides on this, and it's common. Acute bacterial prostatitis is an inflammation of the prostate secondary to acute bacterial urinary tract infection, typically caused by E. coli, found in about 6% of the, 6% of the population. This is a common problem. But I bet you've known somebody who's had prostatitis. Counts for about 8% of visits to a urologist. So the bugs can crawl in through the tip of your penis, through the urethra, and they can go in to the prostate through all these little ducts. These are the prostatic ducts, so it can infest and infect the prostate gland. That's exactly what happens. The infection can cause edema, hyperemia, abscess formation. If it's chronic, it can wreck the prostate. Usually occurs in younger people. The symptoms are a little ambiguous at first. The constitutional symptoms like flu-like symptoms, fever, chill, malaise, achy joints. That can be a million things. Low back pain, rectal pain, perineal pain. Now those are getting, rectal and perineal pain is getting more specific. And urinary symptoms, urgency, that's the key when something's gone. And even urinary retention when the infection gets really bad and you haven't addressed it yet. Prostate can swell and it can kind of beaver dam up the prostatic urethra. So it's super important to treat these type of infections with antibiotics. You don't mess around with these because bacteremia and septicemia can occur and you can die from that. So this is an infection you don't play with. Just like peritonitis, they're prone to develop septicemia. It's a double antibiotic therapy course that's recommended. Trimethoprim and fluoroquinolone are the ones that are usually ordered. And there's a bunch of different combinations nowadays. And it's very important to complete the therapy. You don't want a smoldering infection to be left in the prostate because that can lead to an abscess formation and it can wreck your prostate. And you can get septicemia from that. So finish off those antibiotics. Digital rectal exam will find an enlarged prostate, which will be very tender to palpation. It might even be warm to the touch. Urinalysis will find some white blood cells, even red blood cells in the urine, hematuria. And the diagnosis is made by a microscopic examination of your urine. So you take a sample of urine before you do anything, and then you do a prostate exam and push on the prostate, try to squeeze some of that pus and juice out of the prostate, and then you have the patient pee again to catch that, and you can see if you can catch a bug. You see if there's a difference in the population, the magnitude of bacteria before and after the pushing. And they warn that if the prostate is really, really painful, then you should abort and not push on it. Because that could push the bugs right into the bloodstream and you could get bacteria, emia or septicemia from that. All right, that is the end of Monday and Tuesday. We'll see you guys for the Thursday lecture in this class.